like to move on to our next mental health innovator, which is IRD Global, Aneeta Pasha, the country director for Pakistan, will be talking to us about IRD.
Great, thank you. Hello, everyone. I'm Aneeta Pasha. I'm the country director of IRD Pakistan. I'm going to be talking about IRD's mental health program, but before that, I just want to give a little update on what IRD is. So essentially, interactive research and development, we're a research and public health service delivery organization based out of Pakistan. We started out of Pakistan, and the ultimate goal is to improve the lives of vulnerable communities through innovative healthcare programs. I'm not going to go through this timeline, but this is essentially to show that IRD itself was founded in 2004. And in the last 16 years, we have grown out of Pakistan into a global organization with country offices in 8 other countries from South Africa, East Africa, as well as East Asia. This is just another visual to show the disease areas in which we work. So IRD started out as a TB program in 2004. Currently, we have a very large maternal and child health portfolio. We have programs in infectious diseases, communicable, non-communicable diseases, as well as global surgery. So specifically, I'm going to talk about the mental health program called Pursukoon Zindagi, which means peaceful life. It's a program that I started in 2014. Just to give you a little bit of context, it comes as no surprise that in the mental health state in Pakistan is quite dire. We know that the prevalence of depressive disorders in men and women is very high, as you can see the numbers on the screen. But we also know that there are hardly any, or there aren't enough healthcare providers to meet the need for healthcare provision, mental health specifically. So essentially, Pursukoon Zindagi provides mental health services through an integrated lay counseling model and by leveraging mHealth technology. I will go into the details of exactly what we do in a minute, but essentially we have a community-based arm as well as a facility-based arm. And we try to make sure that we close the loop on healthcare delivery. The program has 3 basic components. So we do demand generation, which is awareness raising, community outreach in low-income communities in Karachi. We have a capacity building component where we train community health workers to be lay counselors. And then of course the service delivery arm. So I'm going to talk about the challenges and what our program is doing to address them and how it all fits together. So as I said, we know there's a lack of awareness about mental health in Pakistan. So what we do is we get groups of 10 to 15 men, women in low income communities. We sit down and we say, let's just talk. Let's talk about what's going on. Let's talk about what's bothering you guys. And it's sort of a guided, facilitated conversation towards mental health. And through these conversations, we talk about what mental health is, what signs and symptoms look like, what to do if you feel like there's something that you are feeling, coping strategies, what to do if you see somebody in your family or somebody around you who may be struggling with mental health issues. And then when and where to refer people if it's something that needs additional care. So in the last 2 years alone, we have engaged over 20,000 people in these small guided group dialogue. The second challenge we are trying to address is that, as I said, we know there aren't enough mental health professionals. So we have developed an 8-day basic counseling training manual, which we have used to train over 180 counselors so far. So again, from these communities in which we work, we take people, we train them to be basic counselors, and they go back into their communities to be able to provide frontline therapy for depression and anxiety in their own communities. We also know that if we, you give the awareness and at the same time you provide the services, there still tends to be a low uptake of mental health services. So people don't come back for their 3rd, 4th, 5th sessions. And so in order to address this challenge, what we've done is integrated our mental health program into primary care and routine primary care services, as well as public health programs that we have for chronic illnesses, such as TB, diabetes, HIV. So when patients come back for the regular visit to meet their healthcare provider to pick up the medicines for their follow-up visits, we make sure that a counselor is there to provide them their next session, or even the program teams of these primary care facilities, the staff is trained in basic counseling to be able to address the mental health as well. As we've talked about, the presenters before have talked about digital health. And I think for us, it's very important to make sure that we're able to track the processes and the data in the field. So what we've done is developed an app. We've developed this app in-house, which the counselors use to register, screen, enroll clients. But at the same time, this is where they maintain follow-up data on their clients. So which visit they're on, what happened in the last visit, when is the next one scheduled. And it allows us to have this entire program be completely paper-free, but at the same time, it allows the program team to look at the data in real time and to keep an eye on what is happening where, in which areas with each counselor, for example. Finally, one of our biggest consistent challenges that we have constantly been faced with has been the lack of adequate space for counseling. So, in the communities in which we work, a lot of, these are slum areas. So in a lot of places, the joint family systems are in place. And so there isn't that private confidential space for people to have a conversation. Similarly, when we work in hospitals or facilities, there's waiting areas that have hundreds and thousands of people, and our counselors are often sitting in a corner and whispering to their client because we just don't have that space for counseling. So to address this, we recently launched our Pursukoon Zindagi Wellness Centers, which is essentially these shipping containers which we have taken and refurbished and renovated to be these wellness centers. And these are some of the pictures of what it looks like from the inside. And the idea is that people can just walk in to just de-stress, speak to somebody if they want to. We can have counseling sessions here. The space opens up and becomes a space if we need to have support groups for, let's say, HIV patients, TB patients, or just the awareness session groups that we're doing. And the vision for this is that some of these would be stationary in some of the facilities where there are very high volumes, but also we would have some mobile centers that would just drive through communities and stop at a particular place and just gather people around to talk about mental health or to just interact and engage with people. What this has also allowed us to do at a conceptual level is shift the paradigm a little bit from illness to wellness. So yes, we're talking about depression, anxiety, and we're talking about the screening and the providing services, but here we also want to talk about positive mental health and use this space to, for example, have sessions on mindfulness or yoga, eventually get kids involved on some play therapy, art therapy. And so this is an initiative of ours that we're very excited about that in some ways can bring it all together. So I'm going to bring you back here to this in a minute. Everything I've talked about falls into this framework. Some of this happens in the community, some of it is happening in a facility. The way we function is that we engage with primary care facilities in low-income communities, and in the catchment area around it is where we will do some of the awareness raising or some of the positive mental health work, but refer back to our counselor who's sitting at the primary care facilities in order to close the loop. So for the last couple of years, just some of the achievements we've had, we've trained over 180 counselors who are currently deployed in the city. We have mental health services integrated at 20 facilities. We've screened over 150,000 people, of which from the 10,000 people presenting with symptoms, we have been able to enroll 9,000 people for individual one-on-one therapy. Finally, looking ahead, what we want to do is, of course, strengthen the program because there's always room to strengthen, but also scale it up. This year, we have scaled this program with 3 of the largest primary care providers in Karachi. And we've implemented this model. And what we want to do ideally would be to scale this up nationally through partnerships, but also see if there are ways in which we can replicate this model in other countries across the IRD global network or even otherwise. So thank you.
Great. Thank you, Aneeta. We have a few questions from the audience, please. Other folks, if you have questions for Aneeta, please type them in using the Q&A icon at the bottom of your screen. A question from Deepak is, how do you identify the cases in the community?
So we use a screening tool. We were using the SRQ-10, which is a 10-item questionnaire, and we have recently shifted over to using the PHQ-9. And so that's our initial screening. This is followed by a locally developed 25-item anxiety and depression scale, which we use to do the second line of screening.
How are you assuring the quality of the counselors?
So what we do is, so we have the 8-day training. In addition to that, each counselor is supervised by a clinical psychologist. The clinical psychologist meets with each counselor once a week for one-on-one supervision sessions. In addition, she will meet with her group of counselors every 2 weeks to do refresher trainings, because obviously it's a lot to soak in 8 days. So every 2 weeks we have a refresher training, because a lot of what these counselors are learning, they're learning on the field as they go. And so this is an opportunity. They may come back and they say, well, you know, this is something that's bothering us, and the clinical psychologist will have a refresher training on that. In addition, we used to do this earlier when we first started in the first 2 years. We would record all of the sessions that the counselors would do in the field, obviously with consent. And then we had a psychologist who would just listen to that and then give feedback to each counselor based on how they were performing. So, you know, she may say things like, at some point you should have probed a little bit more, or at some point, you know, this was a problem area, so when you meet them next week, you can go back. The clinical psychologists, we have 6 on our team at the moment, are working very closely with each counselor. We do spot checks in the field where she will sit in on the counseling sessions that are happening. As our program team does the same to ensure that the quality maintains throughout.
Outstanding. I think we're at the end of our time, but there's one or two other questions. Maybe we can email those to you. Thank you so much for joining us, Aneeta. And maybe you can stick around and answer questions on the chat